Thanks, Grace. And I want to thank the Beacon for inviting me to give the talk. Medical oncologists tend to give the most depressing talk with the most depressing data, so get ready for this. But there is some hope as I will present. So I'm going to be talking about chemotherapy for bladder cancer. So first of all, the basics. So what's chemotherapy? So chemotherapy is a class of drugs that inhibits cancer cells. And the way it inhibits cancer cells is by inhibiting cell division. And those two pictures show the cells trying to divide there, and also by inhibiting DNA replication. So basically, they attack rapidly proliferating cells. And that's why you have side effects such as inhibiting the growth of hair, blood cells, and the lining of the intestine, which is why you get gastrointestinal toxicities, side effects. And nausea and vomiting sometimes is also one of the side effects. Generally, the chemotherapy is administered intravenously. Most of the chemotherapy for bladder cancer is intravenous. Some chemotherapy drugs are given orally, but we don't have oral drugs for bladder cancer. Now, I'm going to be talking about muscle-invasive or metastatic bladder or urinary tract cancer, and not the non-muscle invasive type that you already heard about, for which chemotherapy is given inside the bladder. So this is intravenous chemotherapy I'm going to be talking about for more locally advanced muscle-invasive or metastatic cancer. So for a long time, we have oncologists have liked to combine different chemotherapy drugs. All chemotherapy drugs don't work exactly in an identical manner. They work a little bit differently. So we like combining drugs that work a little bit differently so that they might work together to kill more cancer cells. So for a long time, we've had a regimen called Mvac, consisting of 4 chemotherapy drugs: methotrexate, vinblastine, adriamycin, and cisplatin. And what this table shows is a few randomized trials which compared the Mvac regimen with other regimens, including cisplatin, which show that there is an improvement in survival with the Mvac regimen compared to those other regimens there. So if you see on the right-hand side, the median survival is around 1 year, just a little over 1 year with the Mvac regimen in these 3 studies, compared to the other comparative regimen, the regimen with which it was compared, where it's more like 8 to 10 months. But if you see down here, the 5-year survival is not good. You see about less than 5% of patients alive in this trial at 5 years with Mvac. In this trial, it's a little bit higher, but it was not a long-term follow-up in this trial. The patients do respond, though. You see here the response rate is between 40 and 60%. So response is regression of tumor, shrinkage of tumor by 30%. That's when you look at the maximum dimension of the tumors. So that's how response is defined currently, 30% decrease in the maximum length. So that occurs in approximately 40 to 60% of patients. But despite the high response rate, the median survival is only just around 1 year. And a 5-year survival, you don't see a lot of patients surviving 5 years, unfortunately. So clearly, it's a standard, but not an optimal standard. There is a newer chemotherapy regimen around for the past 7-8 years called GC, which stands for gemcitabine and cisplatin. So 2 chemotherapy drugs combined together, as opposed to Mvac, which is 4 chemotherapy drugs. This randomized study compared the GC regimen with Mvac in patients with advanced urothelial cancer. And basically, the 405-patient trial, and you see here the median survival is very similar, 14 to 15 months. And if you see long-term and you go down here, 4 years, 5 years, a similar number of patients are alive around 5 years, around 15% or so alive at 5 years. So these 2 regimens looked similar in this randomized trial in patients with advanced metastatic disease. But what about toxicity? So for efficacy, you get a similar number of people alive. How toxic is GC compared to Mvac? So GC has significant advantages compared to Mvac. You see here a number of patients dying because of side effects, only 1% in GC compared to 3% with Mvac. Mucositis, which is inflammation of the lining of the mouth, is much more common with Mvac, occurred in close to 22% of patients. Neutropenic infection, that's an infection because of low neutrophil counts, low white blood cell neutrophil counts, which leads to a poor immune system and therefore infections. That occurred much more commonly with Mvac. 15.1% of patients had that side effect with Mvac, as opposed to only 2.5% with GC. Hair loss is also seen with Mvac, while with GC you mostly don't see much hair loss, although you can see some. Vomiting occurs somewhat similarly in both regimens, and that's because the cisplatin dose is similar in both regimens. So cisplatin is the drug that causes vomiting of all of these chemotherapy drugs. So basically, GC and Mvac looked similar for length of survival, but GC looked much less toxic. So based on this, a lot of the community doctors have switched to GC as their preferred standard, although there are still people who prefer Mvac based on the more abundant data for Mvac from many randomized trials. While for GC, we have only one randomized trial showing similarity. What about other side effects of chemotherapy? So cisplatin is the drug that can cause some of these side effects. So kidney dysfunction, the cisplatin can damage the kidney and cause kidney dysfunction, so we keep a close eye on kidney function with a blood test where we can measure the serum creatinine. That's what measures kidney function. So that's why we give cisplatin with lots of fluids and hydration. You can get peripheral neuropathy, which is nerve damage, which can cause sensory symptoms like tingling and numbness, mostly in the peripheries, hands and feet. But it can also cause muscle weakness from nerve damage. So you got to be careful with cisplatin, especially patients who have diabetes and some baseline neuropathy. You want to be careful about cisplatin. And other side effect we see with chemotherapy is low blood counts. I mentioned neutropenic infections from low neutrophil counts, but you can also have anemia. You can have anemia, you can have low platelet counts, and some of these side effects can lead to delays and dose reductions of chemotherapy. So that can happen up to a third of patients, where you need to modify the chemotherapy, reduce the dose, or delay chemotherapy to get patients through it. You also get fatigue with chemotherapy, usually manageable, but sometimes fatigue can be severe and can lead to dose reductions to alleviate fatigue. So how is chemotherapy administered? So chemotherapy for bladder cancer, GC and Mvac, are intravenously given and generally will require a portacath to facilitate chemotherapy. I think many of you might know what a portacath is. It's an implanted device that sits under the skin on the chest wall, and we can administer the chemotherapy through that, inserting a needle through that. So there's no line hanging out continuously. It's all subcutaneous, and that's the safest way of giving chemotherapy, especially with a prolonged infusion that cisplatin is. It's hard to do it through a regular IV line in most cases, or over a prolonged period of time. So how is GC given? That's gemcitabine cisplatin. It's given weekly, once a week, 2 out of 3 weeks, or some people do it 3 out of 4 weeks. And cisplatin is given on the first day of that 3 or 4 week cycle. Mvac is a little more intense. It's given on day 1, 15, and 22 of every 4 weeks. The Mvac is the regimen that causes neutropenic infections more commonly, like I was saying. So this is a regimen for which we would routinely give prophylactic Neulasta, which is a drug given subcutaneously that boosts the neutrophil count and therefore mitigates the risk of neutropenic infection. Also, if you have low counts, including anemia, some patients might need blood transfusions, and to prevent transfusions, we always think about Aranesp or Procrit to boost the red blood cell count. So GC and Mvac, as I said, have been established as standards, similar in activity. And so can we improve upon that? So this is a randomized trial that tried to do that, added a drug called paclitaxel or Taxol, commercially known as Taxol, to GC. It was a big trial, more than 600 patients. But unfortunately, the difference in survival was not statistically significant. Although the median survival numerically looks a little bit better for the addition of Taxol still not highly impressive. The difference was not statistically significant. So basically, adding Taxol to GC did not seem to significantly improve outcomes in patients with advanced cancer. How about, can you tweak Mvac to make it better? So this is a study that gave something called dose-dense Mvac. So Mvac is a 4-week cycle. So if you give it over 2 weeks with Neulasta support to boost the neutrophil count, you can get in a dose-dense version of it every 2 weeks. And this is the only trial that has compared these two regimens. And if you see here, the strange thing about these survival curves is that the median survival is similar, 15 months. So 15 months was the median survival in both of these, with both of these regimens. But when you look long term, when you go out 5, 6, 7 years, you see more patients alive on dose-dense Mvac compared to Mvac was like around 21% versus 14% alive. So it was a small difference. So based on this, some investigators consider dose-dense Mvac to be a little bit better, but this, I caution you that this is the only trial that has compared these two regimens. We don't have a lot of extensive data to confirm these data. So there is an ongoing trial, which I will not get into too much. This is open in Baylor and also, I think, about to open or open at MD Anderson, which is trying to improve upon GC by adding a drug called bevacizumab or Avastin. That's not a chemotherapy drug. This drug is an anti-angiogenic drug. It blocks the blood flow and also seems to improve chemotherapy delivery into the tumor. So this is an randomized trial ongoing right now, trying to improve upon GC. There are other smaller trials trying to improve upon GC. As you can see, most of these trials are using GC as the template and not Mvac to add more drugs on top of it, since GC is a little bit easier to get patients through and a more simple regimen. Now, all patients with advanced bladder cancer don't live the exact same duration. So there's certain things that make some people live longer, some people live less. So this is a study from the Memorial Sloan Kettering Cancer Center in New York, which found that in patients with advanced urothelial cancer receiving Mvac, these two factors were critically important in determining survival. One is the Karnofsky performance status. So performance status is a rough measure of physical activity of the patient. Physical activity, how good the patient is at looking after himself, self-care. So it's a soft measure of physical condition. We don't want to make people run marathons and sprints to find out how fit they are. It's a very rough measure. So performance status, a poorer performance status was bad. Also, visceral metastases was bad. Visceral is internal organs like the liver, lung, or bone, as opposed to soft tissue or lymph node, which was not bad. So if you had none of these poor risk features, none of these two, your median survival was close to 3 years. If you had both of these two poor risk features, your median survival is under 1 year. And if you had only one of these two, it's somewhere in between, around 13 and a half months. So one of the issues that is critical is that a lot of patients are not eligible for cisplatin. So both GC and Mvac have cisplatin as a template, as a backbone in both regimens. But the problem is a lot of patients are not eligible for cisplatin. And why is that? Because of poor kidney function. If your kidney function is not good at baseline, and we measure that by something called the creatinine clearance, which depends on your serum creatinine, but also depends on your height and weight and age and gender. So we put all these things and calculate the creatinine clearance. And if that's less than 60, that is a risky situation for giving cisplatin. You can run into renal failure, and there are occasional patients who end up needing dialysis because of cisplatin-induced kidney failure. Performance status, if your performance status is poor, your physical condition is poor, you're not very active or mobile, then that is also a situation you don't want to be giving cisplatin, because cisplatin can be a rough regimen, and you want to be in somewhat good shape. And older age is also an issue. We don't have an absolute cutoff. Overall, we don't want to hold the age against the patient, but we understand that age is an issue. We also understand that there are some very fit 80-year-olds, 85-year-olds, while there are some very unfit 60-year-olds. So it's really age is just a chronological number. We believe that performance status is more critical in determining how strong your chemotherapy should be as opposed to age. Having said that, I would be nervous giving cisplatin to somebody 85 or 90 years old. So that's a judgment call when we get there in that area. Cardiac dysfunction, someone has congestive heart failure, weak heart. It's hard to get people through cisplatin many times because cisplatin needs IV fluids and vigorous hydration. So giving somebody with congestive heart failure vigorous hydration is not easy. You can get congestion, pulmonary congestion, and run into trouble breathing. If you have underlying peripheral neuropathy, you already have some nerve damage, some tingling and numbness from diabetes or some muscular weakness from diabetes, you would have a problem giving cisplatin unless it's pretty mild neuropathy. So we also know kidney function is quite common. So it seems that kidney dysfunction increases with age. In this study from the Memorial Sloan Kettering, you see here patients age 80 or over, 2/3 of patients had kidney dysfunction. So the older you are, the less your chances of having normal kidney function, and so the less the chances that we can get in cisplatin. So what do we do with patients who are not cisplatin eligible because of poor kidney function or because of poor performance status? This is a large randomized trial that compared two regimens containing a drug called carboplatin, which I have not expanded here. So carboplatin is in the same class as cisplatin. It's a platinum drug, but it's not nephrotoxic. It's not toxic to the kidneys. It's also got less neurotoxicity, less peripheral neuropathy. So it's an easier drug. It does have more bone marrow suppression. It causes more effects on the neutrophil count, but it does not have the same effect on the nerves or the kidneys, and also has less nausea and vomiting. So it's an easier drug. So this is a trial that compared carboplatin combined with either gemcitabine or two other drugs, and basically found the median survival was similar, not good, as you see here, only 8 to 9 months. So suggesting that if you don't get in cisplatin, you will probably have a poorer survival with a carboplatin-based regimen. So similar, but if you see the acute toxicities, the gemcitabine carboplatin regimen had less severe acute toxicities. So based on this, you might consider the gemcitabine carboplatin regimen to have a slight edge, not a big edge, but slight edge over the other regimen in patients who are not cisplatin candidates. We also know that cisplatin regimens appear to be more active. It is not a big randomized trial comparing the two. There are some smaller trials, and we did a pooled analysis. We combined all these smaller trials, and what we found is that with cisplatin-containing regimens, your chance of a complete response, so complete response occurred in approximately 10 to 15% of the patients getting either GC or Mvac, a cisplatin-based regimen. That seems to be the big advantage with cisplatin, a much higher chance of achieving complete response. Also a higher chance of achieving any response, but really the big advantage with complete response. And as you can imagine, you probably need to achieve a complete response to achieve a cure, which cures do occur in a small percentage of patients. And it seems that cisplatin holds a big advantage in that area. So therefore, we really want to get in cisplatin whenever we can. We don't want to substitute carboplatin for cisplatin unless the patient is cisplatin ineligible. So what do we do with patients who are not cisplatin eligible? One, we can do the carboplatin gemcitabine regimen. We can also consider this regimen, which is weekly cisplatin plus gemcitabine. So remember that the standard way of giving cisplatin was all of it on day one, was 70 milligrams per meter square of cisplatin. Now that's more nephrotoxic than the weekly cisplatin. So if we split the cisplatin to once a week, that gives you a less peak level of cisplatin in the blood, and that might be why you get less toxicity to the kidneys with this regimen. So weekly cisplatin and gemcitabine has been given in patients with renal kidney dysfunction, and seems like this is doable, although we don't have good data on comparison of this regimen with carboplatin gemcitabine. There are trials ongoing, so we don't have an established standard for patients who are not cisplatin eligible. So we have all these trials going, which are combining novel agents in patients that are not cisplatin eligible. Now getting to salvage therapy. So far I've talked about first-line therapy. The GC, Mvac, dose-dense Mvac was all the first regimen we want to give in patients with advanced urothelial cancer. What do we do when the cancer grows back? So we have I don't want you to start reading these names here. So basically the table is only here to illustrate that we don't have a good second-line salvage regimen. If you see the data here, that this is median survival, this is median progression-free survival, that's time to tumor growth. So when you look at that, it's clearly very suboptimal outcomes. So median survival is well under 1 year, it's in the 6 to 9 month range with salvage therapy. The median progression-free survival is 2 to 4 month range. So really we do not have great agents in the second-line salvage setting for patients that have growing cancer after first-line GC or Mvac. Now, we tend to use, so basically we want to put these patients on trials, looking at new drugs. If we don't have trials available, we tend to give either Taxol or docetaxel. There are also agents, other agents which we can get insurance companies to sometimes approve. This is pemetrexed, Alimta. None of these agents is FDA approved for salvage therapy of bladder cancer, but we can get these approved on a case-by-case basis because they're on a lesser listing called the compendium listing. So this is the sad state of affairs for the second-line setting, and that's why we want to encourage patients progressing after first-line chemotherapy to get on a clinical trial looking at new drugs. Now, this is the phase 3 trial that was performed in Europe, and based on this, this agent, vinflunine, the chemotherapy drug, is approved in Europe. It's not approved in the U.S. It's not available in the U.S. But in Europe, this was approved based on this trial. However, as you see here, the median survival with vinflunine was only 6.9 months, while with the standard arm, which was best supportive care, no chemotherapy, basically. They went on to get other agents later, but they got no active chemotherapy in the standard arm. You see here very poor survival with vinflunine. But based on this data, though, given this slight improvement in survival by a couple months in patients that were eligible, this drug has been approved in Europe. But as you can see, this is clearly not a big advance and does not, to me, look any better than Taxol or docetaxel, for which we don't have phase 3 trials yet. So there are many trials ongoing in the second-line setting in advanced urothelial cancer. One of the approaches has been to consolidate with a second-line agent in patients immediately after first-line therapy. So what happens is we get in first-line therapy, we get in 4 to 6 cycles, we try to get to 6 cycles if we can, and then we give a break. The norm has been to give a break, follow patients, and give them a second-line therapy when the cancer grows again. But the problem is when the cancer grows again, it can grow pretty fast. Your performance status can decline fast, and then before you know it, you're not a candidate for any further therapy. So one of the approaches has been, before waiting for it to progress, to give them a second-line agent. It's called consolidation, soon after first-line therapy. So you get in 4 to 6 cycles of first-line therapy. If you're responding or you're stable, don't take a break. Get on a second agent. And this is being looked at in many randomized trials with an agent called sunitinib. Sutent being looked at. It's a drug that's an anti-angiogenic drug approved for kidney cancer. Lapatinib, so many biologic agents being looked at in that consolidation space. So now getting quickly to bladder cancer, the staging I won't go through, but I think that you heard already that if you have patients with bladder cancer invading the muscle and beyond, depending on the depth of invasion, your outcomes are different. And if you see here, if you have lymph node positive disease, your chance of being progression-free are quite low, in the 10 to 30% range, as opposed to if you're muscle invasive disease but not in the lymph nodes, you have a better progression-free survival, 40 to 50 to 60% range. The one thing I want to point out is when the cancer comes back, in patients where it comes back, most of the failures, most of the progression is in a distant site. It's not in the area of the bladder. So distant failure you see here is much more common in the 20 to 40% range, while local failure, local progression is not as common. What this suggests is that you have microscopic disease sitting in a distant area, the bone, liver, lungs, much more commonly than you have microscopic disease sitting in the locally, which is why we believe that chemotherapy given intravenously early on is important to get all these distant sites of microscopic tumor cells. While radiation therapy, a lot of patients ask me about, what about radiation? Well, radiation is likely to not have a major role, at least based on these data, because most of these cancer cells are not sitting locally in the area of the bladder. They're sitting far away. So trials giving chemotherapy for this early localized stage of bladder cancer, localized but muscle invasive, have been done. And this is a key trial that looked at 3 cycles of Mvac given before radical cystectomy, before bladder removal, and found an improvement in survival for giving 3 cycles of Mvac before cystectomy. I would call this still a modest improvement. So if you see here, when you get down 5-6 years, you have approximately around 45% of patients alive with just cystectomy, while with 3 cycles of Mvac preceding cystectomy, you have approximately 60% or so patients alive. So it's a modest improvement with 3 cycles of Mvac given before cystectomy. We also know, and I should have pointed out here, is that we achieve something called pathologic complete response, which is no tumor at the time of cystectomy. So that happened in about a third of patients that got 3 cycles of Mvac before cystectomy. We also know that if you achieve no tumor at the time of cystectomy, your chance of surviving are much better than if you had persistent tumor at the time of cystectomy after neoadjuvant chemotherapy. Actually, that's also true for patients who did not undergo neoadjuvant chemotherapy and went straight to cystectomy. If you had no tumor at cystectomy, you had much better outcomes, median survival getting up over 13 and a half years with no tumor, as opposed to patients who had persistent muscle invasive tumor where the median survival was poor, unfortunately, 3.7 years median. So based on this, we also think that if we can add to the standard chemotherapy with new agents, and if we can achieve no tumor at cystectomy, pathologic complete response, we might improve outcomes. We might detect better regimens with this model of combining chemotherapy with new agents and getting that pathologic complete response rate up from over the 30% range up to 40, 50, 60% range or higher. So this is a retrospective analysis which looked at GC and compared with Mvac, and essentially found a similar outcomes, similar pathologic complete response rate with GC and Mvac. And although most of the trials have been done with Mvac or CMV, all the randomized trials with neoadjuvant therapy, I think that most oncologists believe the GC is a similar and much easier regimen to get people through, and we believe the GC is probably a reasonable regimen also to use in a neoadjuvant setting before cystectomy. So there are neoadjuvant trials ongoing trying to combine the chemotherapy templates of GC and in some situation dosed in Mvac, which is at MD Anderson. We had a trial going with GC combining with sunitinib, which we just closed, and there's other regimens ongoing in the neoadjuvant setting. What about post-operative chemotherapy? So post-operative is also called adjuvant chemotherapy, chemotherapy after surgery. So unfortunately, we have no definite evidence from randomized trials. There were a few small trials done back in the 90s, and a couple of them were also were positive. We showed an improvement, but they were very small, and we believe they were not powered. They did not have enough patients to be definite. But there were a couple of small positive studies There were other bigger studies that were performed, which investigators tried to perform in the past 10 years, but unfortunately, none of these adjuvant trials have accrued well and did not complete accrual. So the sad situation is that we do not have definite evidence for the efficacy of adjuvant chemotherapy, although in our hearts we believe that if you can deliver adjuvant chemotherapy, you probably will have similar outcomes. But one of the problems is that when you look at patients who had radical cystectomy, this is from MSKCC New York, what they found is about 30% of patients were not in shape for receiving adjuvant chemotherapy within 90 days. So it might be that neoadjuvant chemotherapy before cystectomy for muscle-invasive operable disease is more feasible. And so you should try to get in chemotherapy first before cystectomy when you can for muscle-invasive disease. Based on the all of these data we have, we just have more evidence for neoadjuvant therapy. And there is a real danger that in the adjuvant setting, after cystectomy, you might not be in shape for chemotherapy within 3 months, because we really want to get in the chemotherapy early, within 3 months, and earlier than 3 months is better. So what about patients who are not cystectomy candidates because of because they're in poor shape, medical conditions? There is some data out there which has combined radiation therapy with chemotherapy, which shows some improvement in outcomes locally. There is no data for improvement in survival yet with this approach. So this is only an approach we would consider in patients who are not candidate for cystectomy because of medical reasons or whatever other reason. There is also this trial which came last year from England, which combined radiation therapy with 5-FU and mitomycin C. And this is mitomycin C given intravenously, not within the bladder, which showed that there was an improvement in local outcomes. No improvement in survival yet statistically. So really, combination of chemotherapy and radiation for muscle-invasive localized disease is, we think, only an option in patients who are not cystectomy candidates. So the way we want to go in the future is to tailor therapy. We really don't know who benefits from chemotherapy, who doesn't. So we are not smart enough for that yet. There's lots of studies going on trying to examine this. We want to give the right drug to the right patient bearing the sensitive tumor. We also want to avoid drugs likely to cause toxicities in patients. So there are some panels which can predict that. So there are studies ongoing in this area, but we're not there yet to predict who benefits from what chemotherapy. So to conclude, GC or Mvac chemotherapy is both standard and also dosed in Mvac. I should add to that. Second-line chemotherapy is not very effective. No FDA-approved options. Trials are encouraged. Neoadjuvant preoperative chemotherapy with cisplatin improves outcomes. And I must add, we don't have data here for patients who are not cisplatin-eligible. So we really don't have any data for neoadjuvant and even adjuvant in patients not eligible for cisplatin. And chemotherapy and radiation therapy combination for poor surgical candidates. And always prefer trials whenever you can, because clearly systemic chemotherapy is suboptimal at this time for urothelial cancer. And I think you heard this before, the pharmaceutical companies need to focus more on bladder cancer because of the high prevalence, although incidence of advanced cancer may be not as high as other big cancers like lung or colon or breast cancer. And someone brought up the cisplatin issue, right? So cisplatin, there is a shortage going on, but I think that we usually can find it, slight delay sometimes, and you may have to change the infusion center where you're getting the therapy. And I have done that a few times recently, but hopefully we can resolve this issue soon. Thank you.